Okay, welcome. So we've got Sam here. Really nice to see you. Thank you for joining us. We are recording this so we can give it to the members to watch later on. We do understand that we can't please everybody with the times that we're doing this. So I'll just introduce myself. I'm Sarah Catlow-Doggett. I am the chairperson of the STO. And I'm really excited to kind of start this series for our members. We've been doing Research Friday, which is like really informal, but it's very written. So we've decided to do these really informal chats where we'll talk about some evidence-based stuff. We do have a guest with us today, and I will introduce them in a minute. And what's really exciting is a lot of members have engaged and actually have sent me some questions through, which is really great. So we'll look at answering those. So I'd like to introduce Darren Crocker. He is our new member of our executive committee here at the STO. Really excited to have him on board and his experience. So I'm just going to let Darren do a really brief introduction about himself, and then we'll go in and kind of talk about electrotherapy and all the things related to that.
Hey, hi. Thank you, Sarah. Hello to the STO membership base and also the wider sports therapy community. So I am primarily a HE lecturer. So I joined Sarah and the fantastic team at Marjon University in Plymouth, 3.5 years ago, Sarah?
Yeah, roughly.
Prior to that, I worked at City College Plymouth via Plymouth University, where I headed up their sports therapy curriculum and their degree pathway, as well as sports rehabilitation. I'm currently a senior lecturer at Marjon and also a senior fellow of the Higher Education Academy. In my 20 years within industry, I've taught for about the last 20 years, but during this time I have worked in private practice, professional sport, including football, rugby, basketball, golf, ran a private practice, and also spent 4 or 5 years as the sports therapist for GB diving.
So lots of experience, and we're really excited for Darren to be on the STO committee. As you know, we're trying to push the profession forward within evidence-based practice, and we understand about CPD and how expensive it can be. So we're trying to give you little snippets. You know, you might really want to dip into something and not something else, and that's completely fine. But today we've noticed obviously a big kind of increase on the members kind of page and non-members page about questions about electrotherapy. We can't cover it all today. This is a really informal kind of very short, snappy kind of CPD kind of broadcast, I suppose. It's the first one we've done as well. So if people want to give us feedback, we would really appreciate it. We're complete novices at this, so we're learning lots of skills as we go through as well. Now, we can't cover everything today because we only have a very short amount of time. I know that some members and non-members have commented, or can you talk about this? Can you do this? Or messaged us. We will look at running some more of these, obviously not every week, but we'll look at running some more of these and hitting actually what members want or want to hear about. But we'll start off. Darren is our expert on this at the university. So he teaches it all. He really engages with it, and he knows all the up-to-date research within this area. So I'll hand over to you, Darren.
Yeah, thank you, Sarah. So as Sarah alluded to, we at the STO have had lots of questions regarding what modalities people are using in sports therapy. Some questions, I think, Sarah, regarding appropriate CPD. And I think most of our questions lately have revolved around the use of laser, or as we more recently term it, photobiomodulation therapy. And also shockwave therapy, which in itself is a very broad term. In addition to that, I think a lot of our members are still using therapeutic ultrasound and also TENS and interferential therapy, in addition to neuromuscular electrical stimulation. More recently, I guess, in industry, we've seen TCAR therapy, a re-emergence of diathermy, sort of thermal therapy. And we've also had a few kind of broad questions regarding superinductive system. I think kind of based on volume of questions, the amount of interest we've had, we'll probably focus this on our historical trends in therapeutic ultrasound use, look at the emerging technology and modalities with PBM and shockwave therapy. But I think we absolutely at some point could maybe look at delving into these more kind of contemporaneous modalities, such as SIS and TCAR.
Yeah, because I know quite a lot of members are going, can you talk about this? And you're like, oh, I'd love to. But we will look at doing more of these and adding, if you've got comments about what you like to see, you can always comment, you can message us. And this obviously is open to members, non-members. So just to kind of educate everybody. So where would you like to start, Darren? Where are we going to start today?
Oh, you tell me, Sarah. Over to you.
I don't know. Should we start
Fire
with
away.
diagnostic ultrasound? Because I do have some questions from some members about it, but we'll start with diagnostic ultrasound to start with.
What would you like to know?
So with diagnostic ultrasound, kind of when would you use it? How would you use it? And kind of just go through some of kind of maybe the settings and some of, I don't know, the evidence-based practice that's out there.
Yeah, I think you mean therapeutic ultrasound.
Sorry, did I say diagnostic? Yeah, sorry, therapeutic. Sorry.
Okay, no worries.
It's been a long day.
I think we're probably in the minority of practitioners who still strongly believe in some of the therapeutic physiological benefits of therapeutic ultrasound. I think if we look at the evidence-based literature, of course, there's a growing body with shockwave therapy, a growing body of literature supporting the use of laser or photobiomodulation. Having said that, I do believe there are still some benefits with therapeutic ultrasound. First and foremost, I guess it's a lot cheaper than shockwave and a laser or PBM therapy.
Because I mean, know for those of you, therapeutic machine, sorry, is about what, £900? How much is a
anywhere from
shockwave?
£800 to £1,000, yeah. Depends. I mean, this is where when we come on to shockwave, we need to make a very clear distinction between radio pressure wave, shockwave, or focus shockwave, and then that all falls under the broad term of extracorporeal shockwave therapy. And this is where I think we're seeing some kind of gaps and limitations in the literature. But for those not overly familiar with therapeutic ultrasound, the human audible hearing range is anywhere between 20 to 20,000 hertz. But any frequency above 20,000 hertz, obviously is inaudible to the humans, and therefore becomes ultrasound. So we primarily use therapeutic ultrasound for tissue healing to kind of mediate the tissue healing sort of process, and maybe some benefit on sort of pain, but primarily for sort of soft tissue healing, I would say. Ultimately, it's using acoustic sound waves, and it's a type of reverse piezoelectrotherapy. So what we mean is we are simply using an electrical current to generate acoustic sound waves that then propagate into our target tissue with the aim of improving cell permeability, increasing protein synthesis, and therefore kind of mediating the healing process.
Do you think it has a more of a placebo effect?
Or do there is a placebo effect, I'm sure. I think there's a placebo effect with pretty much every treatment, every modality, every conversation, every interaction we have with all of our patients. I don't necessarily, I don't know if I should say this, but I don't necessarily care how it works as long as it works. So the argument I have with therapeutic ultrasound, and I know the literature is somewhat grey and not overly kind of conclusive. Personally, from experience, I think people underdose with therapeutic ultrasound. So we're probably most of us familiar with the recommendations from Professor Tim Watson with regard to treating an acute, a subacute, a chronic injury, i.e. maybe 0.1 to 0.3 watts per centimetre square for acute, 0.3 to 0.5 watts per centimetre square for subacute, and then 0.5 to 1.0 watts per centimetre square for our chronic-based presentations. I don't know if you can agree, Sarah, but over the years when I've been in electrotherapy exams, I think anecdotally students are almost scared of going above that 1.0 watt per centimetre square. We know that ultrasound as it enters our biological target tissue, some of that ultrasound will be attenuated, so there'll be a loss of ultrasound at depth. So obviously if you're looking at your 1 megahertz therapeutic ultrasound application, that's really there to target deep tissues anywhere from say 2 to 4, maybe 5 centimeters beneath the surface of the skin. And again, my issue, and I think this is where a lot of the kind of previous literature hasn't necessarily accounted for this loss of ultrasound at depth, is they don't allow for that loss.
Yeah.
So
Because they changed the timings of it, didn't they? So they updated the timing calculation of how long you should put ultrasound onto that area to kind of counteract that, didn't they? But yeah, you're quite right. It's how the size of the area, how you move the head of the ultrasound, and what is actually going into that injured tissue.
Yeah, absolutely. So as an example, if I'm using kind of 1 megahertz therapeutic ultrasound and I'm treating a lesion at depth, I typically, settings on the machine allow for an additional 25% per centimeter. So if you're treating a lesion, that's say 4 centimeters beneath the surface of the skin, let's say a relatively deep sort of muscle, vastus intermedius as an example, something like that. Yes, it's a chronic base injury. We kind of want 1 watt per centimeter square at the site of lesion, but this is where on the machine we'd actually set the power to 2 watts per centimeter square to allow for that loss of ultrasound at depth. I read a recent paper, I think it was a 2023 paper actually, and this quite surprised me actually. But it was 5 minutes application at 1 watt per centimeter square of power or intensity, using a 3 megahertz ultrasound applicator. They looked at sort of skin temperature for an infrared thermometer, and 5 minutes application increased soft tissue temperature by 4 degrees Celsius.
Oh, wow.
So when I look at the thermal effect, lots of us, if we've kind of got, I don't know, an achy back or kind of tight, cramping, spastic, sort of tonic-based tissues, we generally advocate the use of heat for that kind of thermal effect, that increase in tissue pliability, extensibility. So even just when we look at the thermal effect with continuous ultrasound, obviously we're not going to get that with our pulsed applications, but there has to be some degree of effect, I believe, because you are heating tissue. What we've struggled with in the literature, I believe, is to sort of quantify the magnitude of that effect. And this is where I think a lot of studies, one, have perhaps not explored the treatment modality correctly on their settings, but then also kind of failed to consider, well, one, the depth and loss of ultrasound, but also how do we then quantify the effect?
Yeah, it's quite interesting, isn't it? Because I feel within research, we concentrate, oh, we really love this one paper. And then suddenly one person does it, and then there's that cascade event of everyone follows it. It's like certain rehab programs, isn't it? It's like one person does it, and then it becomes a trendy thing. But there's very limited evidence base kind of information about why we should do it for, and kind of how we're working with that tissue. So that always makes me smile in research when, you know, there's so many different ways we can do stuff, isn't there? And it depends who you read and what their opinion is on everything. So
I think I thought about this 2 days ago in terms of our next kind of block of electrotherapy kind of sessions. Is again, we obviously do a lot of our teaching sort of case-based learning where we kind of work towards scenarios. But you know, let's use an infrared sort of thermometer. Let's test skin temperature pre-application, post-application. Let's kind of play around with the power settings. Let's also play around with the time, looking at those calculations based on how many heads it's over the lesion, etc. But let's also play around with frequency and sort of see what effect it does.
Exactly. I think, you know, we should always push research and not believe everything we read sometimes. Maybe I shouldn't say that, but, you know, it's very true. Researchers are out there to disprove or to prove something, and it's where we go. I actually have a question from a member, how exciting, about ultrasound. So they're a massage therapist, and they would like to expand kind of their skills within clinical practice. And they were asking about how can they qualify using ultrasound, kind of some examples of maybe some things they can do, because I know we've discussed this as well. You know, and where can they learn about it so they can add it to their tools and maybe their insurance as well.
I think with a lot of these modalities, if you buy a machine off a manufacturer, they do provide some degree of training or introduction to the machine. I think it's part of our upcoming kind of STO CPD portfolio. You, me, and one of our colleagues is also looking at kind of running a series of electrotherapy based CPD courses as well.
Yeah, so that's a good point. So I kind of introduced that. We're in the, just so members, so all the members that are actually watching this, you get a bonus bit of information. We're in the process of right now of developing a CPD series for sports therapy. We have our platform, and as Darren just said, obviously myself and Darren have been teaching sports therapy at degree level for over 20 years. I hate to say that. And also another one of our colleagues as well. And we're developing an online and a face-to-face CPD kind of series for our members and non-members as well. And one of the big things that we're looking at is doing very short, snappy kind of CPD with a certificate at the end of it, kind of on the theory of electrotherapy, therapeutic ultrasound, you know, what you know, we will devise or design courses that members would like. And then we will then look at doing face-to-face ones. So actually going through the machine, showing you the settings, how it works, and some of the theory behind it as well. We're really excited to look at developing that. We think it's really, really important. One, we have to do CPD for professional development. Two, CPD is super expensive sometimes. And obviously there will be a charge, but we're looking at doing affordable CPD for members. Even though both of us are based in the Southwest, we'll be looking to expand our face-to-face kind of services as well. So if there's any courses online or face-to-face that members would like, again, just let us know, because we want to develop stuff for you and what you need, not what we would like to teach. So but yeah, I think it's important. I think just doing a CPD course with the competencies tested and a certification and giving that will allow you to gain that little bit of extra insurance as well thing. So Dana, that was a really great introduction about ultrasound. We use it in clinic a lot. We teach it to our students. But obviously we've got some new exciting machines in our commercial clinic where myself and Darren work. So we're going to talk a little bit about those machines that Darren has managed to get us, which is very exciting.
Where should we start?
Oh, I don't know. We've got lots of new machines in our clinic.
We have. Let's go for laser.
Okay. Yeah.
Okay. So if you're not familiar with laser therapy, essentially we are using light therapy that radiates through the skin, interacts with our target tissue, and it can speed up ATP synthesis. So therefore the cell has more energy to speed up protein synthesis, and it also has an analgesic pain relieving effect as well. So the acronym LASER stands for light amplification stimulated by emission of radiation. And although this technology kind of has been around since the 60s, maybe, when we looked at our first invention of the ruby sort of rod crystal or ruby rod laser, now we've moved more towards our modern semiconductor lasers. And that's typically the ones you're going to see in our kind of commercial sort of therapeutic environment. We've also moved away from the term laser because obviously you say laser to somebody, they think kind of tattoo removal, hair removal, Star Wars, very kind of, you know, pew, pew, pew kind of thing. And when we look at all of our kind of therapeutic interventions, nothing should really hurt in sports therapy. I'm a great believer of that. Yes, we can experience a little bit of discomfort, but we shouldn't be looking to hurt our patients. So what was it, 2014, I think it was, the North Atlantic, or the North American Association of Light Therapy and the World Association of Laser Therapy generally starts to steer us more towards this kind of PBM, photobiomodulation therapy, which sounds much nicer to our patients and less kind of fearful, less scary than say we're going to use lasers.
And how beneficial is it? Is it kind of what injuries do we use it on? Kind of the evidence that it does work?
Yep, so there is a growing body of literature supporting the use of PBM. Again, it kind of makes, it's quite important as to what type of laser you're using. So there's different classifications of laser based on how powerful they are. So anything less than, say, 500 milliwatts is classed as a 3B laser. Obviously, we have lower level, but they're not really therapeutic. You know, that's your CD sort of writer, your laser pointer, that kind of thing. Most clinicians, I would advise to go for a class 4 high-powered laser, and that's essentially anything that's over 500 milliwatts. We've recently secured a 30-watt laser, Sarah, isn't it?
Yeah.
And the benefit of a more powerful laser is, one, it can clearly penetrate and absorb into much deeper tissues, but we also have a much more dynamic treatment. So when we compare that to our historic low-level laser therapy, that's, one, quite superficial. It's also quite a lengthy treatment. You know, we compare that to our kind of high-powered or high-intensity lasers now. We are maybe treating for a few minutes compared to maybe 45, 50 minutes. And it gives us lots of time. Yeah, it gives us lots of time in our session to explore clinical reasoning, to kind of build up that kind of rapport, that dialogue with our patients, do some manual therapy, some soft tissue, some mobilizations, to go through our exercise-based prescription. And it's a nice adjunct to everything else we do in sports therapy.
Yeah, I was going to say, I've had laser treatment, and you know, for me it worked. I don't know if that was psychological or whatever, but it is actually quite a relaxing treatment. With it, you know, I had an injured shoulder, which we thought was frozen shoulder, but it wasn't, and I had some nice laser treatment on there, and and it was really beneficial.
So I mean, if we look at the biological effects of laser, I guess there is a photoacoustic effect, and this is where we're administering light energy in the form of photons that radiate through the skin at a really high intensity but very pulsed, so lots of repetitions. That can interact with the nociceptors or the free nerve endings to have that analgesic effect. Of course, if we go towards a continuous kind of application, we have a thermal effect, which we know has an analgesic effect that makes tissues much more soft, pliable, extensible. That may help to increase cell permeability. But the main benefit with photobiomodulation is its interaction with the mitochondrion of the cell. And this is known as the biostimulation effect. And ultimately, light therapy is absorbed in water, in hemoglobin and melanin at certain wavelengths. So the sweet spot for therapeutic intervention is anywhere between, say, 600 nanometers and 1300 nanometers. Most machines have a scatter to absorption kind of ratio of around maybe 1000 to 1100 nanometers. Then that just means you get a very good level of absorption in water, in melanin, in the hemoglobin, and it just means that a lot of that kind of light irradiation isn't absorbed just in the epidermis of the skin. It can then kind of absorb and transmit further into our deep tissues. And ultimately what it does, in a very simple explanation based on our time, I guess, because I'm very mindful looking at the clock.
I know, we've really got 6 minutes left. Goodness me.
It kind of shuttles oxygen through what's known as the chromophores. That's that kind of sits on the periphery, the boundary of our mitochondrion. It then interacts with one chromophore known as cytochrome C, where it kind of increases or interacts with ATP synthase to ultimately increase ATP production to stimulate protein synthesis in the cell. And light therapy is the only modality that does that, actually. So this is where I see an explosion of interest in the future. And maybe, even though I'm an advocate for TENS, therapeutic ultrasound, I do see a growing body of therapists going down the PBM laser route and also the shockwave therapy kind of route as well.
And I've seen a massive increase in kind of private clinics that maybe offer, I'm just going to use the umbrella term shockwave, but they're offering more shockwave therapy within their clinics, which is obviously income generating for them quite a lot. And that seems to be the real trendy way for certain injuries, isn't it? Like tendinopathies, for example, to treat kind of those injuries and obviously other injuries. But so it is quite interesting how the trends of sports therapy and what we treat and the modalities that we use kind of swing, don't they? You know,
it's absolutely. Coming back to your kind of your trend, there's a little bit of momentum behind certain therapeutic kind of modalities, but I do think kind of PBM, photobiomodulation, and shockwave therapy. This is where we're having a growing body of literature supporting its therapeutic benefits, whereas the therapeutic ultrasound literature is somewhat inconclusive, I would say.
Yeah, it was very, very big, wasn't it? The, you know, therapeutic ultrasound kind of literature was, you know, there are two main forces within that, you know, got Watson and I can't remember the other guy's name. That's really bad.
What modality was this? Electrotherapy in general?
Yeah, the two main authors in electrotherapy.
Obviously
Watson.
Professor Tim Watson. I think Kathy Speed did a lot
Yeah,
as well, but Cliff Eaton, he's the guy ultimately who trained me. Unbelievable practitioner, particularly when it comes to kind of the use of electrotherapy and electrophysical agents. Yeah, very knowledgeable, co-authored with Tim Watson, so very knowledgeable chap. Have we got 5 minutes to talk about Shockwave?
And Tim Watson actually teaches sports therapy. Yeah,
there's lots of brilliant sports therapists out there.
Yes, out there. Yes,
present
we have,
company included. Yeah,
obviously. So yeah, we have a quick thing just for you to go into Shockwave. We can obviously run more of these if members are interested. So
yep. So most of us will be familiar with Shockwave, or more broadly, kind of extracorporeal shockwave therapy. This is where we have to make a clear distinction between focused shockwave, which is much deeper, more powerful, very much kind of works to a very, very small 4 to 8 millimeter sort of focal point. That is available for sort of commercial clinical use, whereas I think most sports therapists at the minute, particularly their first sort of venture into shockwave therapy, are buying a radial pressure wave.
Is that because the prices are different?
Machine. Or it's when we look at the waves. So a radial pressure wave is low to medium energy, whereas a focus shockwave is kind of medium to high. So in its nature, it's more therapeutic. It's less destructive or non-destructive. But when we look at this acoustic sound wave, it will kind of diverge and radiate outwards. So it covers a larger area, more therapeutic, whereas our focus shockwave is very much more kind of concentrated and maybe a little bit destructive in terms of breaking down scar tissue lesions. And that focus shockwave technology actually came from lithotripsy, so destruction of, say, kidney stones. So therefore we can appreciate how powerful that would need to be and how important it would be to kind of hit the correct spot. But yeah, I think most people now, particularly are when they kind of go into sort of shockwave initially, are looking at radial pressure wave machines. The way I look at shockwave, and ultimately it's just an acoustic sound wave that propagates into the tissue and has a whole cascade of physical and sort of biological effects. Some of the physical effects will be maybe a breakdown of scar tissue. It may help to dissipate substance P away from the subcutaneous layers of skin, which we know will help with pain perception. And of course, there's a whole discussion another day in terms of what is pain. It's multifactorial. It's not just physical, obviously. There's a whole range of sort of biological effects. So maybe increase in bone morphogenic protein to stimulate kind of non-union sort of fracture healing, endothelial nitric oxide synthase, which is a precursor to nitric oxide production, which we know is a vasodilator, vascular endothelial growth factor, which helps with angiogenesis, revascularization, proliferation cell nuclear antigen, which is a precursor to RNA, DNA replication repair. So all of these factors are going to help to increase our protein synthesis and that repair. The issue we have, I guess, with sort of shockwave is that it may be slightly pro-inflammatory, whereas our laser light therapy, we can kind of perform daily, multiple times a day, if we like. With our shockwave therapy, particularly if we're treating our athletes, our patients with tendinopathy, plantar fasciopathy, trigger point therapy, some of these may be quite aggressive. So it's generally advisable that we have a good 48 hours between sort of treatment interventions. The way I think of shockwave, and that this is really good for chronic-based presentations that have displayed failed healing, it's kind of like hitting Control Alt Delete on your laptop, resetting the injury, and then obviously mediating that inflammatory process correctly with our kind of sort of appropriate load management, our soft tissue, exercise-based therapy.
Yeah, it's a great way to put it,
etc.
isn't it? And I think as well, you know, lots of things come out in sports therapy and people want to try everything. And I think it's really important to understand what that machine does and how it works with the body and understand the stages of healing, so you are supporting those stages of healing, and helping that body heal quicker or rehab quicker. And that's why it's really important not just to buy a machine or say, I'm going to use this in my clinic. It's actually understanding the theory behind why you're using it.
Yeah, absolutely. Obviously, you've got to be very, very careful how you convey that information to your patients. They don't want to know all the ins and outs, but you have to kind of be confident in that we know of the purported physiological effects, biological effects of that modality. But very quickly, I think most people generally start with radial pressure wave therapy because they're a lot cheaper than focused shockwave. It's still going to set you back several £1,000s for a good machine. So anywhere from maybe 6 to 12,000, maybe £15,000 for a really good shockwave or radial pressure wave machine. In contrast to focused shockwave, it may be 2, 3, 4 times the cost of that.
Yeah. It is quite shocking, especially if you own your own kind of small clinic. You know, can you afford these machines as well? It's and how are you going to make a profit out of them realistically with that? Well, I'm going to call it to a close. Thank you, Darren. Hopefully meet myself and Darren, and we'll invite some other guests on. Well, obviously we're not doing these every week, but you know, maybe once a month, once every kind of 5 weeks, just to kind of, one, show our face to the members. We write a lot of stuff, and it is having that conversation, and so you can kind of see who we are and kind of what we do. We're always open for members to tell us kind of, actually, can you do one on this, or can you discuss this? We're always happy to take that kind of feedback. And this is obviously going out to members and non-members. So again, if you're not a member of the STO, we do offer a lot of extras for our members as well. But I would like to take this time to welcome Darren to the committee. It's great to work with someone that is so up with the trends within sports therapy, and hopefully we can pass that on to all of our members. So thank you. I hope everyone's enjoyed it. Our first one. So there we go.
Thank you all. Thank you, Sarah.
Thank you.